So good morning again. As I was listening to the discussion yesterday, I heard a lot of conversation primarily about hurricanes and some other types of natural disasters like tornadoes and earthquakes and wildfires. But my first comment was just to remind the committee or see if indeed your mission is to address other types of disasters as well. So I'm thinking things along the lines of chemical and radiological attacks, human-induced disasters like the Deepwater Horizon oil spill. So just want to kind of make that as my first comment, that as in the field of disaster epidemiology and the methods that we develop for tracking morbidity and mortality following these disasters, and they are applicable to all types of disasters, small-scale disasters, large-scale disasters, and whether it's natural, human-induced, or terrorism. So with that, I'll move into my other prepared remarks. As this panel is intended to do, we're looking at best practices for the real-time collection and dissemination of data. And I have briefly will mention 4 promising practices related to mortality data, and then I have a few comments on morbidity data as well. So starting with mortality data, the first thing I want to mention, and this was covered yesterday, was the importance of ensuring that all medical certifiers understand the importance of recording disaster-related information onto the death certificate and that they know how to do so. So as part of our CDC's capacity building in this arena, we have developed 2 tools which were shared with the committee ahead of the meeting, and we believe continued dissemination and training of those tools is one would be helpful. The first tool is the death scene investigation after natural disasters or other weather-related events. That tool was published in 2017, and it provides checklists, forms, and other resources that the death scene investigators can use for specific types of disasters. So there's forms specific for hurricanes, tornadoes, and earthquakes, and heat and cold events as well. So the purpose of this toolkit is to ensure that there is high quality and consistent data collected at the death scene, and that information is then available to inform the medical certifier's determination of the disaster relatedness of the death. That data can also provide additional details to public health in terms of understanding and studying risk and protective factors for mortality. We have recently developed and provided an online training module for this toolkit, and it is available on CDC's Train website. The second tool that was also provided is the reference guide for certification of deaths in the event of natural, human-induced, and chemical radiological disasters that was published in 2017. This builds on a publication by Coombs in 1999 in the International Journal of Epidemiology. And in both that article and in the reference guide, we provide a case definition for disaster-related deaths and, again, instructions on how to complete the death certificate and ensure that information is recorded on the death certificate. Through the 2017 disaster supplemental funding that Congress provided, CDC is providing training to Puerto Rico, USVI, and the state of Texas on this reference guide so that their medical certifiers have the most up-to-date information. We hope to be able to support additional training, but at this time we don't have a lot of funding to do so. And we also have, will soon be releasing a 30-minute online training of the reference guide that'll be available on our website and will provide continuing education credits. So the second promising practice I want to briefly mention is enhancing electronic systems by adding prompts such as flags, alerts, to things such as the medical examiner case management system or the electronic death registration systems. These alerts, for example, in an EDR, can help remind a medical certifier that they should send the death certificate to a medical examiner if they think it's disaster related. So we heard an example of that, I think, from New York, from Tara talking about New York City yesterday. And similarly, there can be flags in the MEC case management systems that can be used, again, for a medical certifier to be able to quickly indicate that they believe the death is related to the disaster. And this can happen even before it's certified or registered. And then it provides an opportunity to quickly count and record those cases. The third practice I wanted to mention, and this might not be a best practice in the traditional sense, but we heard a lot of conversation yesterday about improving communications between some of these stakeholder groups, including the medical examiner coroners, vital statistics, and epidemiologists. I think in particular it's important to have the vital statistics and the epidemiology in the planning and the exercises and drills along with the MECs and the emergency managers. And then the fourth thing I wanted to mention related to mortality is considering policy level changes, and that can increase the timely reporting of disaster-related morbidity and mortality. So again, we heard a couple examples of this yesterday in the state of New York, requiring that a death certificate be initiated within 24 hours. In the state of Florida, requiring that once the governor has declared a state of emergency, that the MECs or the medical examiners report twice a day. So there's a couple examples, and I'm sure there are others, of policy level changes that can help speed up the process of reporting this information. So with that, I want to transition to morbidity data. Our experience with CDC's experience with real-time morbidity data kind of falls into three areas. And the first is conducting surveillance of sheltered populations. And so we have collaborated with the American Red Cross and our state, local, territorial partners to develop data collection tools and processes for real-time collection and transfer of data from shelters to public health agencies. These populations and the types of injuries and illnesses that are going to be seen in a shelter medical clinic are going to be fairly minor and not maybe capturing the severe morbidity that the panel has been tasked to address or the committee has been tasked to address. So in terms of thinking about more severe morbidity, those individuals are likely going to be treated in hospitals or emergency departments. And so there was some discussion of syndromic surveillance yesterday and whether or not that's on the table for the committee to consider. But there is, I think, an opportunity to use that data. And the talk yesterday focused a lot on infectious disease, and they use the syndromic surveillance for that. But just as a reminder, syndromic surveillance can pick up injuries, motor vehicle crashes, violence, mental health symptoms. So there's some opportunity there. And we also recommend that if states have existing surveillance systems or existing ways in which they get data from hospitals, that they just use those existing systems in an emergency and not necessarily try to create an ad hoc or a new surveillance system. And then the third source of morbidity data is that I want to mention this morning is Poison Control Center data. So the American Association of Poison Control Centers and CDC have worked together since about 2001 to develop, enhance, and maintain the National Poison Data System. And this system captures information on calls to all of the 55 regional poison centers in the United States, and the data is uploaded to the national database every 8 minutes. So it's very much a real-time system. And we can talk a little bit more, because I know my time is up, about how this might be used, but I think I wanted to mention it. In a natural disaster, it may not be as useful. We tend to capture things like carbon monoxide poisoning or gasoline exposures, calls from the public. But in a chemical or radiological event in which there are complex or novel exposures that healthcare providers might need treatment guidance on, they would be, I think, more likely to be calling the poison center to get advice from a medical toxicologist. And so I think that's a potential source of morbidity data in a certain type of disaster. And I will end there.